Hello and good afternoon, everyone. Thank you very much. A very warm welcome to everyone who has joined from around the country. We are hosting a webinar today. So my name is Cal McGregor and I work for the Emergency Care Improvement Support Team. I have two of my colleagues, Angela Bullivant and Liz Sargent, with me, and we are also supported with the Better Care Fund team. So thank you very much for your support behind the scenes and in developing this webinar. We have done this webinar on the back of the guidance that came out in March, the Hospital Discharge Service Requirements. And what we've managed to do is we have kindly got 3 systems from around the country. We have North Tees, we have Swindon and we have South Warwickshire who are going to share their experiences, and I'll introduce them in just a second. But they've developed their discharge to assess processes and methods of working so to enable people to go home, and we want to use that home first mindset and use discharge to assess to get people home and not go into a bed from a hospital, to make sure they get home and get as independent as possible. So thank you very much for joining us. Just a few things. There is a chat room function, so none of you will be, as participants, will be able to speak, but you will be able to post your questions in the chat room. We will really endeavour to get to all the questions as much as possible. What we're going to do is hear from all 3 systems first. We will then have maybe 30 to 45 minutes to answer your questions. So we've got people in the background trying to theme the questions. What would be really helpful is if you can put your, with your name, you can put your role or your workplace or region. That would be really helpful. And if you have a question directed specifically to one of the 3 systems, could you put North Tees, Swindon or South Warwickshire after it? And then we can pose it directly to the person. We hope to be running on time, so we have started now and we hope to finish by 3 o'clock. If we have not as many questions as possible, we might close a bit early. But thank you again for joining, and I will let all the speakers introduce themselves. So thank you very much.
Hi, my name is Siobhan Smith. I'm a senior clinical professional from North Tees and Hartlepool, up in the northeast of England, and I'm an OT by background.
Hi, my name is Simon. I'm the head of physiotherapy at Breakfast.
Good afternoon, I'm Tracy Sheridan. I'm the Associate Director of Operations within the Out of Hospital Collaborative, which is part of South Warwickshire Foundation Trust.
Next slide.
Hi, so we're up first. As I say, I'm Siobhan Smith from North Tees and Hartlepool, and we're going to be talking about our integrated discharge team and some of the pathways we've done in COVID to support that. Next slide. So our integrated discharge team is a team consisting of OTs, physios, social workers, nurses and the voluntary sector. We've got approximately about 40 whole-time equivalents that's within that team. We work with the strapline Home Safe Sooner, and we've been using that since 2016. It's been a strapline that's been agreed across all of our local authorities and local partners, because we really felt that it was about building a team and relationships to address problems and not do that in isolation. We have took the mantle around trusted assessors and HomeFirst with our therapy team, so we use that in various different ways throughout our organisation. We are quite a high performing trust. We've got a low level of detox, so since August 2018 our detox have been at about 2 to 2.5%. Today they're running at 1.78%. In terms of length of stay, we have the best performing trust in the region for length of stay. So we've been doing quite well. What we also have with our integrated discharge team is we also have an integrated single point of access as well that we manage our discharges through into the community. With our therapists with our integrated discharge team, it's very important for us to help maintain their clinical quality when they're delivering care on the wards, which is a little bit different to the sort of smaller discharge liaison team, but we've really sort of focused on this Home Safe Sooner approach with them and the HomeFirst. Next slide. So the pathways we're going to be talking about today, I'm going to go a little bit further with sort of the 4 key components that we've developed through COVID, which is the stroke pathways, transport and discharge to assess. And I'll go into a little bit more about those as we go on. Next slide. So our discharge pathways that we have within our trust, we work on red, amber, green pathways. The top right corner is what we have on our admission documentation, so we do that as soon as a patient comes in. We took the decision to keep those pathways the same during COVID, but what we really wanted to do was strip out the inefficiency. So we looked to work with we work across 3 local authorities in our area, and they agreed quite rapidly to look at one assessment tool for all of the pathways, which was used on an SBAD process. The graph below is our percentage of discharge on per pathway from Q1 last year to Q1 this year, and obviously Q1 this year was peak COVID time. This data actually is a bit of a challenge to us because, as you can see, we had a lot more patients discharged on the amber pathway, which is into intermediate care beds, as opposed to going home. But we still had 50% of our patients going home. For us, this is around, we can't have our cake and eat it. We can't have a low length of stay without sort of that community infrastructure. Our average length of stay for over 65 in our trust is 5.5 days. So our next challenge is how we deliver this at scale, and challenging ourselves for a system to do this. Next slide. One of the pathways that we want to talk about was stroke. Stroke is our stroke areas was one of our toughest nuts to crack in terms of discharge to assess and our home safe sooner pathway. Based on the fact that the complexities of the patients and the complexities of the discharge, but what COVID actually allowed them to do was really take on that mantle. So what they did was they extended their criteria for early supported discharge. They did have an early supported discharge team prior to COVID, but the criteria was quite limited. You had to be quite high functioning to be able to be supported by that. What they did with COVID, through COVID, is that all the patients got picked up through early supported discharge, as well as our community teams also supporting prioritising patients with high to moderate rehab needs in the community as well. One of the ways that they did that was they embraced technology. They started using video consultations in the community and also on the ward. So in our acute areas, our therapists use video conferencing for all sort of environmental visits, for all follow-up visits, for liaising with family, and they've really took that on and embraced that. And I'm going to coin the phrase early on, it's their new normal. Had we tried to implement that sort of pre-COVID, we would have had a lot of barriers there. So they've really kind of took that on. We know we've got challenges within our area of in order to sort of look at the reduce the length of stay in the stroke unit, we had to discharge patients into care homes, and that comes with its own challenges, such as space, environment, and the length of stay. But what was really important to us was the outcomes. They had to be better. We had to make sure that these outcomes for patients going into intermediate care were better, because we were discharging people earlier, and it was a better experience for the patients. Next slide. We did have a video, and as I say, that hopefully will be available a bit later, from one of our senior OTs, Nicole, who works on the ward. And what the implementation of discharge to assess on the stroke unit really kind of challenged their focus. The stroke unit, a lot of their goals and ambitions was what suited the professionals as opposed to what was right for the patient in terms of whose rehab journey is this, because they were taking on a lot more risk. So in order for us to see a significant shift in terms of length of stay, we need to really work with our therapists on the ward around their experiences and really focus on it's the patient's journey and tackling some of their anxieties around that, which they did, and they took up really well. So that's been one of the really positive things that we've done in our area through this period. Next slide. So one of our key enablers was transport. You're probably thinking, why have we included transport? But we recognised that in order to facilitate discharge to assess, one of our key enablers was having available transport. We had some early quick wins with this. So in order to support this, we buddied a therapist up with our hospital transport team, and they actually went with them, took patients home, and took them home over that front step and managed and part of that journey. So from the beginning of April to the end of June, they did 242 journeys, and this was in our Doblo. So we have a Fiat Doblo within our trust, which is a quite large vehicle that we can transport patients into. That is wheelchair accessible, that the guys can drive, and we had a bus that was provided to us by one of our local partners in order to support transport home. I've just added in there around the trips of the days of the week. As you can see, a lot of our journeys did happen sort of mid-week late on, so we still got a little bit of work to do around weekend discharges and beginning of the week. But really having those therapy intervention at the home address was really beneficial. So the guys picked up sort of additional stair assessments that were traditionally done in hospital, organising equipment. Yeah, they did over 3,000 miles and over 190 journeys. And of those 190 journeys, they traditionally would have been patients who required home with a wheelchair and assistance of one, that we would have transferred them with our ambulance service, which is quite a costly service, and we just want to look at the efficiency of that, of why not have one of our therapists take them home and support that actual journey into their house. Next slide. So yeah, this is the team. This is our transport team. We have Laura and Julie there, and Laura and Julie actually don't work in acute services. They were redeployed as part of COVID. They work in outpatients, so this was really new to them, and they really embraced it. So they're there with Artif, who drove our T-Flex bus. So they use this to transport people home. The feedback from them was really positive. That they got a lot of satisfaction from facilitating that journey home. So we can't leave it there. Unfortunately, we've had to have the conversation with them this week around they do need to go back to where they used to work, and we've got to look at how we keep that going. And one of the ways we're going to do that is look at our volunteer drivers and a HelpForce initiative to really look at how we can take this forward and sustain this into the future. Next slide. So again, we had a video, but hopefully we can get this available later. But this, we just wanted to talk about one of the stories with Andy, one of our acute physios, and one of our patients, Ma. Andy is one of our band 5 acute physios. You can see he's very acute. He still got his stethoscope around his neck when we took him back out to meet Ma. Amar was in hospital for a long time with COVID. He was very, very poorly. He was on ITU for a long time, and he just wanted to get home. He had quite a traumatic experience in hospital. Andy's been working with him to get him home and to get him safe, because he lived in a house with lots of stairs, and he knew the right thing to do was just to take him home and assess him there. The day he actually did take him home was quite, in Amar's words, it was a little bit interesting. He actually fell when he got out the car. He then fell again when he got into the house. But we really were working with Andy about not focusing on that as a negative, but focusing that as a positive, and how he should embrace that positive risk taking, because in Amar's words, to get home, it felt amazing. What we are looking at, again, from a discharge to assess perspective, is it's in its purest form. So following some of the stuff we've done through COVID, we've got some transformational projects, and one of them is looking at discharge to assess and trying to test zero inpatient rehab in hospital. Bit of a bold claim, but we're working with especially our new members of staff as well. We really want to try and embrace that going forward. Next slide. So the positivity that we had kind of rippled throughout the teams. this is Jake and Alex. Jake and Alex again were redeployed into our acute areas during COVID. They usually work in outpatient physiotherapy, and they were working on the acute wards with a lady, and it was Friday afternoon, 3 o'clock. The lady was due to go home, but she had long-term oxygen. She was COVID positive, and it was just going to be a little bit too hard to do for the wards. But Jake and Alex looked at each other and went, it's not for us, we're going to take this lady home. So they took her. She was actually going into a care home, but for her, that's where she lived, that's where she wanted to be, and she wasn't very compliant when she was in hospital because she wanted to be home. So the guys took her. She got very emotional, the lady, but it had a really resounding impact on these therapists, so much so that Jake wanted to post this to the rest of the world on his own social media, Facebook. But the thing that really got us was that bit where he says, although it doesn't sound much, I feel amazing, and at times like this remind me why I love my job. And as a therapy team lead working with Home Safe Sooner and working towards this for a number of years, to hear that from an outpatient physios particularly was really satisfying, was amazing. And we're really working with the staff to manage this risk and not to over medicalise people in hospital, and just let's just try it and see how they get on at home. Next slide, please. So we know we still have work to do. We know we've still got to change hearts and minds. As I say, we are high performing with our length of stay, but that does come with its challenges. We need to look at our community infrastructure. We don't have 24-hour support, 7 support for patients at home. Ultimately, what we've got at the moment is patients going into community beds. So that's one of our next challenges going forward. We want to continue to embrace technology. COVID has absolutely catapulted us to do that, as you know, as we're here today using technology, and in terms of how we deliver patient care, we want to continue to do that. But we've got to invest in our community services. We can't do this alone. We're quite lucky within our area because our community services come within our trust and we have a shared leadership across there, so we're able to influence it. But actually the infrastructure out there we really need to work on. One of the things we want to do is to stop measuring the outcomes of patients at the point of them leaving hospital and continue to measure them incrementally into the community. I mentioned at the beginning that we have an integrated single point of access that we have within our areas that manage those discharges home, that manage those discharges into the pathways, but also support those patients once they're in the community, working with our GP partners as well. So that's one of our next things that we want to try and work on and look at and sustain going forward. Next slide. This isn't sort of in reference to hospital food or anything like that, but this we just wanted to add this sketch that was completed by one of our acute OTs. In fact, all the sketches, hopefully you've seen them throughout the presentation, have been done by Vicky, one of our OTs, because she lives and breathes this and she's depicted it really well with her sketches. So we just want to show that, you know, they own this. It's very much part of what they do. One of the things we want to do going forward is looking at how we keep our patients active when they're in hospital, and look at preventing deconditioning. So working with active hospitals and look at the population health agenda within our area. So that's everything from us.
Thank you very much, Siobhan. That's great. And I will pass over now to Simon Lovett from Swindon.
Hi there, thank you, Callum. So I'm presenting on behalf of a few people because really the thing for me that I took away from the work we did in response to COVID was about the collaboration across the system and how we all work together and really truly got rid of the barriers between health and social care. Next slide, please. So we had a few challenges, like most people, I'm sure, and these are kind of our top 5 that we had to manage all the way through, and still actually we're still talking to our team about their anxieties and the uncertainty in the future. As you'll see, we did that through a lot of communication, which was positively received. We had a brand new discharge support team. We'd redesigned it just prior to COVID breaking, and about 80% of our team were new into the NHS and they'd only been in the team a week. So for those guys, well, for all of us, it was a steep learning curve, but for those guys especially, it was it went through the roof. And there was a daily challenge all the way through, and still, I think, for lots of people, in the rate and pace of change and the way we're doing things. But we all banded together and overcame that. Many of us who got involved hadn't been that heavily involved in the discharge work prior to this, and it was the first time we've been working together. And then lots of us were trying to lead this work and work as a team remotely, and that was a real challenge and a personal challenge for myself within that. But I think actually, as you'll see, we turned our challenges into our strengths, as Shizuko has suggested. Next slide, please. So how did we do it? We did it with an integrated approach, and that really was an integrated approach. We had our community therapies, nursing staff from our hospital working alongside our social care teams, alongside charitable funds and private sectors, to really get our service going 7 days a week, 8 till 8, to make sure that holistic needs of all our patients were met. And that ranged from getting them out with the right equipment to making sure they had hot meals where some people's families couldn't bring their food round. And I think lots of people know how difficult it was to do a online delivery through COVID. Next slide, please. Okay, so we achieved, I think we did well, and I think we did stop for a second and reflect on that and enjoyed it, and then we got stuck back in again, really about making sure we sustain out the other side of COVID and keep this going. We got our bed occupancy rates down to 50%, and we've managed to keep our turnover of medically fit patients going beyond the peak. Bed occupancy is not 50%, it's higher than that, where we've lost beds out of the system from social distancing, and that's where the sustainability around our discharge planning has really come into play and been really important. We dramatically reduced our number of medically fit in our hospital. Unlike Siobhan, we weren't one of the highest performing trusts prior to this. But we've managed to get ourselves onto a really good footing, and we're hoping to keep taking that forwards. And I think at the best day we had the lowest number of 7 medically fit patients in the hospital at the close of play, when we were working with numbers of medically fit people around about 50 as an average. So it's just testament to all the hard work that went into this. Next slide, please. So how did we do this? We pulled together. Next slide, please. We really, everybody got stuck in, and they got stuck in from the start and really worked their backsides off to make this happen. And similar to lots of places, I'm sure nationally, people dropped and moved from outpatients, if we're thinking about therapists, into inpatients, into the community setting, just to do whatever was needed. And people worked above and beyond their scope and above and beyond their pay scales, and nobody was afraid to do that. Or people were anxious, but it was about supporting them through, and how we did that together. We used a single referral form across our area, because we border lots of different places, and we tried to keep things as simple and as slick as possible. We moved our staff into skills buckets, as we called them, where we did a skills inventory, put that against the risk assessments, and then looked to see how we could move the people with the right skills to the best places. And that included, I think one of the key things for us was our acute therapists, moving out with their patients into the community to support them, supporting the community staff, and really that collaboration and conversation between all the partners involved in this. We had twice daily calls running 7 days a week to talk about these people we were trying to get out, and that had everybody from equipment stores to therapists to nurses to doctors to social workers, to some of our voluntary sector guys, to see actually what can we do to enable these people to get to the right place for them that's not the acute hospital as quickly and as safely as possible, and to keep them there. And this was a solution-based conversation that we tried to get going, and there was no blame in that, and we kept that really clear all the way through. Yes, there was constructive challenge, but that was good constructive challenge. It really was about us working together. Next slide, please. And my own personal reflections on this, having sat back and thought about this presentation, is how overwhelmingly proud I am of all of my colleagues. And, you know, that goes for all of us, I guess, that are here thinking about how we responded nationally to this stuff. Everybody really just did get stuck in together. And from doing some of the feedback work we've done with our teams, as things have started to settle down a little bit, what's come back loud and clear to us is it's about that communication. And I know that sounds a bit boring maybe, because it's always about communication, but it really did underpin everything. We had daily comms all the way from the head of the CCG down to our healthcare assistants and our discharge support workers, you know, working face to face with those patients to get them out. And it felt like we were all pulling in the same direction. And that hasn't stopped, and it really did feel truly integrated. And I think one of the things that enabled us to do that was that we had support all the way through, and that support wasn't just there telling us what to do and how to do it. It was here's what we need to do. This is a big challenge for all of us, but actually we're going to give it over to you guys. It's the clinicians that know best how to look after those patients, to work out the solutions. It was the trust was there and the permission was there for us to get on and do this work. And I think everybody took an awful lot out of that. Next slide, please. So this is just really for reference of our complex system made simple. If you think that looks simple, that's great. But that's what we did, and that's how we worked, and everybody worked to that. Next slide, please. And then this is us up in this little red circle in the top left-hand corner of your screen as part of our bigger services that we're running across Swindon and slightly wider than that into Wiltshire, and how we all fitted together and were supported through a coordination hub that met daily. And we could take some of our challenges to that hub and you know, throw the ideas around and get connected with the people that could really help us to solve some of these trickier issues that made, for us, discharging some of our more complex patients a bit more doable and achievable. And we could also then feed into lots of other ideas. Next slide, please. And then this is where we're at now. So it's about how we go forwards, and I guess, like everybody that's seen positive change within their organisations, it's now the question of how we sustain this. We moved people around. People were happy to move around, but similar to what Siobhan was just saying, we have to redeploy people back to their jobs, because that's their job, and we need them to do that job now. As the services are coming back online again, using outpatients is a good example of that. But we're really looking to work on that. And one of the key things for us is how we develop those plans of our acute therapists that know the patients, have started some of that assessment, not all of it, some of that assessment, to follow those patients out into the community. Everyone's on board and everyone's up for that, to then hand those patients over to community colleagues to enable that to happen. We've got some work going on around addressing social admissions. You know, there's people that come in alongside their loved ones who are poorly, but if their loved one is in hospital, they've got nobody that can look after them. So there's work going on that, alongside us looking to do some admission avoidance work with our primary and community care colleagues. You know, systems always play a part in this, and by systems I mean, you know, informatics and intelligence and patient management tools. Prior to COVID, we were very fortunate that we could share some of that information with our social care colleagues. We could use that system as a referral system, and we're continuing to do that. We're continuing to build on the good things that we had pre-COVID that worked, the good things that we had during COVID that worked, and the new ideas that were coming in. And part of that, we've got a new head of flow. Got to name drop Sarah Knight into this. She's come in and she's helping us drive this forwards and onto a new direction, where we can make this stuff really sustain and promote discharge as a specialty and everybody's responsibility, because there was a sense of a feeling prior to this, and it's a sense I've personally found in lots of places where actually it feels like it's somebody else's job. We've all got a role in this, and it's how we all do it together. And that's me. Thank you.
Thank you very much, Simon. And we're going to go on to our final speaker, Tracy Sheridan from South Warwickshire.
Thank you, Callum. So going into the pandemic, Coventry and Warwickshire system was in a very strong position. We had trusted leaderships. Sorry, next slide, please. We had trusted relationships from the boards to the front doors as a result of many years of working together. as providers and commissioners across the health and care system. We'd established discharge to a place in place since 2013, so we have got a long history with discharge to assess, and SWIFT is an integrated acute and community provider as well. And so over the years there has been a culture shift to deliver more and more out of the acute and closer to home. Next slide, please. So I think we've seen this slide a couple of times this afternoon. So we're all aware of the national discharge at pace and the expectations that was delivered, you know, at the beginning of the pandemic. And to be honest, the changes that were expected of us was a breath of fresh air. I think as a system, it was what we'd been working towards for many years. But of course, there's the legislation, you know, there's all the challenges and the barriers that every organisation has to work within. So as we know, that guidance said that all patients who no longer had the right to reside in an NHS bed needed to be transitioned home. Really was the best place for those where possible, with those wraparound services. So our pathways have always pointed to that home first, those pathways 0 to 1. And where that wasn't possible, then obviously, you know, we've got the pathway 2 and 3 available across the system. I think with pathway 3 especially, it was more of a challenge as we moved through the pandemic, and I'm sure we can all sort of relate to some of the care home problems that created some of those problems and challenges for us. Next slide, please. So what did we do? So we very quickly identified system leads and execs and senior managers at a very high level who basically supported all the changes, gave that permission. You know, we empowered all our clinicians and we supported them to support in new ways to deliver that safe care. We had, like other speakers have said, you know, we also had twice weekly virtual meeting groups, and these were, you know, sort of real operational groups to high exec meeting groups as well. We had once weekly joint commissioning board focusing on system capacity. We had all our lead providers there. We developed new ways of working and processes, and we agreed those collaboratively, including, you know, members around the table was infection control and the voluntary services as well. We also developed a daily discharge tracker so that we could sort of work and understand what was happening with all the services and the organisations with partners. Next slide, please. So I think this isn't a great clear example, so I apologise for that, but I know the slides have been circulated, but this is an example of the overarching discharge pathway, and on the left hand side there you can see some of the key partners, and I think more importantly, because some of those partner roles and responsibilities changed, it became very clear on who had took on responsibility for what. So, you know, at the top it begins with the board rounds, it moves itself down into our single point of access and how they supported all our pathways for our pathway 0 patients as well. Next slide, please. This slide describes our local interpretation of the guidance, and on the right hand side, again, it says the services that are falling into each pathway with clear, as I said, roles and responsibilities for each of those areas. And I think that you know was really important. So every area really did understand what their responsibility was, or any referring agencies, they were very clear on who was taking responsibility for their patients. Next slide, please. I'll just pick out a few examples from this slide, because it is a bit of a busy slide. But some of the changes that that we put in place at pace was, so some of the CHC assessments were normally undertaken by our complex discharge team, and our CHC teams were redeployed so that they could then take on our pathway 3 patients. As I said, our single point of access, that was utilised as a single point of contact for all discharges, and all discharges had a wraparound support from our community teams, whether that was a social care community team or a health team. Reablement services, they were then committed to bridging for care providers until the care package was actually set up. And HomeFirst Health, they bridged for the positive patients where there may or may not have been a likelihood of those patients becoming unwell again. So health became more involved with those patients as we as their conditions stabilise. And Age UK, they were redesigned so that every patient on a pathway 0 to 1 received a welfare check, and if needed there was an escalation to a named clinician. So every patient had a named clinician that could be contacted following discharge if that was required. Next slide, please. But we could only do this, I suppose, by building capacity. So building capacity in the acute, but also building capacity out in the community as well. And all services stepped up to provide 7-day working, district and borough housing teams, equipment services, the clinical practitioners. We extended their hours, our integrated care coordination, we extended their working hours. Out of hospital priority 2 patients were stepped down in line with the national guidance, and we worked with carers and families and dom care providers to provide some of those checks and low level care needs for some of these patients. So that really then started to create capacity for how then we responded to more of the poorly patients. And what we have to remember here is a lot of patients really did not want to go into hospital. That was the other end of it. So it was around how we actually worked with those poorly patients to reassure them to respond, worked with our primary care colleagues to keep them at home as much as possible. We also had direct access to our senior consultants for advice. So we set up Consultant Connect. We had 7-day working there. We had it till 8 till 8 for our community teams. We started at pace building in some of our heart failure pathways and our diabetes pathways that we were working on as part of our models of care. And where we created that capacity, it became very, very obvious that it was needed also to support some of our end of life. So we certainly saw an increase in our patients who were dying at home, and that in some areas was as high as 30% patients staying at home, surrounded by the appropriate services. Next slide, please. So this slide demonstrates, and again, apologies, it's not the best, some of our system approach to contingency planning and how we built this together. And I suppose it was really the first time as a system, as a whole system, that we had a contingency plan that we all worked on together and we agreed. So the left side of this, describes sort of the pathway 0 to 3 and the end of life. With our focus, as I said earlier, always being on home first, trying to ensure our patients go home or remain home. And the yellow part of that is that home first pathway. The green part is for COVID negative patients who maybe needed 24-hour support, and we couldn't get them home even with our wraparound 24-hour services. And then we did have some blue system-wide pathway beds. We didn't have a lot of those, but those were for those patients where we started to have some problems with our care homes accepting some of these patients back into them. And so as a system, we created and very quickly mobilised these blue system beds. But also what we had was we had patients who were I suppose now medically fit for discharge, but swab was still saying that they were positive, and they lived with shielded patients, so therefore we couldn't send those patients home. And I'm sure these stories are very familiar to everybody. And so, you know, in some cases the blue beds for the whole of the system became sort of a temporary accommodation until we could get them safely back home. Next slide, please. This is just an example of a system tracker, so developed really so we understood the demand and capacity by each pathway, and this has helped us. We very regularly do what we call our point prevalence. In fact, we've done one yesterday as a system, because we want to see if some of our point prevalence work that we've done previously, which identifies where patients should be. We want to see how during COVID it compares to historically, but what that point prevalence does is it allows us to work out where the patients in the system should really be. So we're looking forward to actually seeing those results come through in the next couple of weeks. So this is, we've got 3 acute organisations that we work with across Coventry and Warwickshire, and this is just UHCW. We do have, as I say, one per organisation. So the numbers are quite low on here, and that is really because this is for the rugby half of the Coventry part of the system. So it is a little bit different, but this actually just provides us with information per pathway on the discharges of those patients. And next slide, please. So this is just really some of the, I suppose, the health work that we put in place at PACE, and I think it's fair to say throughout all this, these were all our ambitions. It just meant that we were able to sort of really work and remove those boundaries. So the red half of this really is around the the 2-hour urgent response to keep patients safe and stable. As I said earlier, a lot of the patients really were concerned if they had to go into hospital, and we worked with we were able to still do things like PDSAs, because we did a PDSA with WOMAS to avoid conveyances into hospital and to keep patients with that wraparound, and some high-level ACP clinical practitioners, consultants coming out to support these patients at home. And we worked very closely with our primary care and frailty teams as well. And the green half really was, I suppose, supporting the shielded, the vulnerable patients with that technology and those regular phone calls, and again making sure that we'd got the right technology to support those patients at home. And then the final slide, please. So as a system, with lots and lots of positive developments, and many of them, we have been working on for a long time, and it just gave us, as we've all said, that permission to remove barriers and at PACE move forward and on things that we'd wanted to do for a long time. And the benefits, to the patients has really been very clearly noted. Thank you.
Thank you, Tracy. That's great. So that was great to hear from all 3 systems around the country. So thank you for taking the time to deliver your presentations. Just to reiterate, we are recording this webinar, so it will be available on the Better Care Exchange. If you're not already registered, you can use the email address that's on the bottom of the screen, england.bettercareexchange@nhs.net, to register, and you'll be able to get access to the recording. For all the participants that are viewing just now, you will get sent the slide deck, and you can obviously share them with your colleagues. And we will be using the chat room. We have we'll be keeping the chat room and looking at all the questions and developing a frequently asked questions document. So hopefully that'll come out in the next kind of week or two. We will now, without further ado, go to some of the published questions that are there. So my colleague Angela Bullivant is going to be fielding the questions to each of the three presenters, and my boss will also help to answer any questions and support you as may I do. So thank you.
Thanks, Callum. So the first question, please, first set of questions for Siobhan. Is the integrated discharge team hosted by the acute provider, or is it by the community health trust provider? And that's from Kevin.
Hi, we're a joint provider, so our community services come within our trust. So the integrated discharge team, the majority of the whole time equivalents we said there are part of our NHS trust. We see our social care colleagues very much part of the integrated discharge team, but they are managed by their own local authority. So we're a joint trust between acute and community.
How do you assure yourselves about the quality of rehab and outcomes for patients who are stepping down to care homes? And that's from Lee.
I mean, that's a really good question, and that's something that we are working on. As I said, it's around, from our discharge point, it's not just the point when they leave the hospital, it's there's other outcomes out there. So we work very closely with our community therapy teams, and we are working on, we've used lots of different outcome measures out there, but nothing really kind of fits. So if anybody's got any new ones, that'd be really interesting to hear. We work on sort of readmission rates and back into hospital, but we don't have anything sort of specifically that covers the board. What we do have is the strong links with the community teams through our ISPA. So if there were any particular issues, or quality issues, we pick it up there, and we're very integrated with the leaders within our local authorities as well. I don't know if there's anything you want to add there, Jill?
I think it's just about making sure that we have some nationally recognised standards around how we measure outcomes. I think we're very good at looking at quality and looking at what the patients, how we're delivering care to the patients. But I think what would be really good is to see that movement of the old DTOC language out to the communities in terms of incremental points in time to see how people are getting on following their discharge.
Thank you. Did you use just the commission transport for the trust, or did you use therapy team specific transport?
We used a mixture of everything. So we have our hospital commission transport. And what was tricky with particularly using those guys is they don't take one patient per journey. So we have, as I mentioned, we have a Fiat Doblo, which is we can able to transport patients in. But what we were provided from one of our local councillors was called T's Flex buses that weren't sort of in operation during COVID because they used to take people out and about in the community. So they redeployed them to our trust, and we used those guys as well as the transport we have in the hospital, as well as our transport team as well.
Thank you. How many hospitals have you got as part of North Tees, and do all sites use the process that you're describing?
We are, again, probably quite fortunate because we only have one acute hospital within our trust. We have 2 hospital sites, and our site at Hartlepool did have beds on, but due to COVID, those beds closed, and all acute beds were on one site based on oxygen and things like that. So we only have the one.
Thank you. How do you decide which patients were suitable? And then how did the service link to voluntary sector, and did that work?
Do you want to answer that one?
Suitable for anything specifically? Suitable to go home?
Yeah, which patients were suitable to go home?
I think for us during COVID, because it's evolved so quickly, the staff have identified the patients, and I think it goes back to the point that someone made around giving permission for staff to do that, and they know their patients the best. We didn't want to restrict their thinking by giving them criteria. We just gave them permission to say, if you've got somebody who will benefit from getting home and realising what they can do back in their own environment, then just do it. And I think that's why it grew, and it's got so much potential, because the staff need to be able to have some autonomy really in doing that, and that worked really well for us. There are certainly patients they wouldn't have chose to do that with at the moment, but I think it's about giving passing that decision making to them and putting in place what you can to help them do it.
And the links with voluntary.
The links, yes, we're very lucky here. We have a thriving volunteer base up here. We have community hubs that I think for everybody during COVID we're thriving. I think what's really important for us now is how we, from a COVID recovery and rehab perspective, link back in with those hubs. We've had hospital from home from hospital even, voluntary services over the years, and some have come, some have gone, and I think what we've learned now is that we're embedding a pathway where our own volunteers support that, which is growing. There's a national help force. We were an innovator site for a help force project, that has certainly got more potential that we could probably share through the better care, the exchange, so that people can see what we managed to do there.
Maybe a slightly trickier one, probably not, but could you give an example of what 24-hour care might look like?
At home?
Yes, please.
I would love to think that it's something that is digitally enabled, that we best use what we've got. We don't all have a lot of things available overnight. I don't know whether everyone else is the same, but it's about using what you've got to their best. We have urgent care centres that have primary care in, for example, overnight. We have ward and control facilities. We have patients who are able to use technology. And it's about what you do with what you've got, and I think that's what we're keen to do now. Enhance it, don't get me wrong, we need to get the right response at 2 o'clock in the morning, and that's something to look at as a system. What we know we can't afford to do is put somebody into everybody's house for 72 hours or 7 days or whatever it might be. So we've got to look at what we can enable across the system, because if we just do it in isolation, it would cost so much money, it would be unsustainable.
How does Discharge to Assess work with people who have got dementia?
I would say it probably works best for people with dementia. I think the key thing for those patients is it's about how are the families coping, how are the carers coping. That I think is probably something locally we need to still work on. I think sometimes patients and their families come in and they're exhausted, and it's about how we support them back in their own environment. But for us, that group of patients, they'll benefit the most from Discharge to Assess, as long as the support networks are there for the family and the carers.
Thank you. Was social care part of the integrated approach? And that's from Sarah.
Yeah, integral. Yeah, they always have been for since we started Home Safe Sooner, back 4 years. I always say it's like trying to have a football team without a goalkeeper or a striker. You've got to all be in it together. Siobhan alluded to it. We're not employed by one organisation, but it's never caused us problems. We're still classed as a team, and I think during COVID, it's challenged some workforce departments have dealt with COVID differently to others, and I think we've then had virtual links into social care. We still locally would drive an on-site model for part of the pathway, because we do believe that the skills complement each other from a health and social care perspective.
Is it just the therapists who take people home, or do other members of the multidisciplinary team do it as well? And that's from Mary.
So during COVID, it's predominantly been our therapists, to be honest, and some of our band 3, band 4 staff in enhanced roles. They've predominantly worked with our transport scheduler. We just see absolute links between the two. It's not just about the journey, it's about what we do when we get back home.
But if there was another member of the MDT who wanted to do that, then we would absolutely, you know, encourage them to do that if that's the right thing to do.
Please, can you clarify what areas of the community services require any further investment? That's from Annie.
All of them.
Yeah, I would probably say definitely our community therapy teams, our community nursing team, our community. Particularly our community matrons. They do an excellent job supporting patients at home and in care homes, but we really need to build on that. Yeah, all our specialist services, our intermediate care, our reablement, we are looking at how we integrate our intermediate care across the services. We're doing a lot of work around that out in the community. So yes, children, all of them, but we very
You can work differently though, and I think what integration is helping us to see is that you can create additional capacity by doing things differently, and we've done that. And to be honest, we've never had money since we started this 4 years ago. So when we're saying anything and everybody, it's because, to be honest, we've never had anything. We've been very innovative, but I think we are at a tipping point where without investment we're going to struggle to push any more boundaries than we already have. We created frailty coordinators from existing budgets. It's been very, very creative with what we've had. Yeah.
So just linking on to the budget slightly, Sam has asked, are there any details that you might have on any cost savings attached to this?
Not yet, no.
Okay.
We're working on that.
Working on that one. Was there any impact on the readmission rate if you were unable or to access or to find care in the community? And that's from Helen.
No, so I think what we our plans and what we would do is we wouldn't class it as a readmission at the moment. We would keep the bed open until we had stuff in place. We get care up here within 2 hours in all our localities, so we don't envisage that being a problem, and it hasn't been so far.
Perfect. And final question, you'll be pleased to know, how do you backfill? So if the acute therapist isn't on site because they've taken someone home, and then there's another acute discharge into that empty bed, what happens then?
It's $1 million question. You have to be even more creative and find therapists off trees. No, I think that's exactly what we're battling with now, and there's got to be some double running. It's about thinking a bit differently. We've got some cracking volunteers that are supporting some of our basic levels of care and support in ward areas, and I think that we're on that journey right now, so let's all learn how we do that together, I would suggest.
Thank you ever so much. I think that's it now for you. Thank you very much. So I'll go over to Simon now, if that's possible, please.
Hiya.
Hi, Simon. Shez has asked, how did you create discharge to assess model, and what did it consist of, please?
I think how we created it is we very much used the COVID-19 discharge guidance as a template and built our services around that. Obviously, every area has to adapt because every area is different and develop things slightly differently. I think probably the best way to describe how it actually functions is almost to follow the journey through, I guess. And initially in COVID, and it's changed a little bit since then, we pulled all of our discharge support workers and bolted that team up. We pulled them away from the wards because of infection control risks. So they were doing lots of telephone conversations with the nurses, which at the time the nurses hated because it was interrupting them from delivering their care, but actually they got very used to it very quickly, which meant that, you know, they'd pick the phone up, we'd be asking the right questions, they'd give us the information, and then we'd facilitate the referral out, and then go back if we had follow-up questions from social care colleagues or community colleagues to enable getting the discharge moving as quickly as possible. We moved away from that because we want more integration back in at a ward level, and that's involving an awful lot of education, which is great, and everybody's on board with it. But once the referral was taken into the almost a virtual discharge hub, if you like, comprising our guys in the acute, community therapy, social services, we'd look at who was best placed and how we'd get them out. And in fairness, a lot of it came down to, particularly in Swindon, the strength of the response from our social services colleagues in the way that they just pulled people out. And lots of the calls that we were having daily, we'd be talking about specific patients of, okay, we've got this person, they need a QDS care package, we haven't quite got the carers in the reablement team, so that's when the therapist would offer to jump out and go and help, or the long-term care provider that we work with would step in and say, okay, we've got some capacity, we can bolster you up. Or our community therapy colleagues would say, right, we can get there tonight for the welcome home visit, and getting them into bed and getting them sorted, and then the care package could start the next day. So that's kind of how it tracked through, I guess.
Thank you. Did any of your social workers stop working in the hospital, leaving the nurses and the therapists to complete the discharge? And that was from Linda. Yes,
all of them. We moved them all out virtually. We had prior to it, we had Warwickshire and Swindon social work. There are our two predominant teams that we work with. We're based up with our occupational therapists and our discharge support team, and we moved them all out virtually. And that was a challenge. And again, where we were filtering the referrals through using the guys in the discharge hub, that allowed us to collect and collate the information together, and the discharge team at that point comprised of therapists and nurses, rehab assistants, and our brand new discharge support workers who were had very little experience in the NHS prior to joining us. So it's a huge learning curve for everybody. But again, that's where the conversations between an individual social worker and one of the discharge hub workers, it would be so crucial in that learning being live as we were going, and I think that's what really helped us to get it through and to move the volumes of patients that we did safely.
Thank you. What process did you use to assess patients who were being discharged from hospital? Where did they happen, and what did the assessment look like?
They happened where they needed to happen, and I know that's might be not the best answer, but they'd start in the acute, because the acute therapist or the nurses would have that information, and then it would pass through and follow them out. So almost part and part. It wasn't all in hospital, and a lot less happened in hospital, but it was that exchange of information, and then the social service, the reablement teams and community therapy teams getting in quickly to pick that up and carry those assessments on. And that's again, and it sounds like Siobhan's guys are doing it as well, and looking similarly to how we follow people out with therapists. So, as a therapist, I'll see somebody on a ward, and it doesn't matter how good my referral is or how good my telephone handover is. I've assessed that patient and I've worked with that patient. If I'm the one that then goes into their house, looks at their environment, I'm already one step ahead of the game to, make sure that everything gets done properly. So I really think that's the way we're going. And coming back to Siobhan's colleague's point about how we keep that cycle of staff going through without running out of people in one place and having everybody out in the community, we're trying to crack that nut as well.
What management or brokerage system do you have in place for your intermediate care beds or your discharge to assess beds? And that's from Steph.
So our intermediate care beds in Swindon, we have a facility on site at Great Western Hospitals, which is a 60-bedded unit where we do our intermediate care and rehab, and we're very lucky to have that as part of our organisation. Our discharge to assess bed is own beds in Swindon are owned by Swindon Borough Council, and we again it came down to the conversations, and still comes down to the conversation of who's got the best capacity to manage those patients. So we flexed our criteria a lot. So sometimes patients that would probably be better in a discharge to assess bed went into our rehab unit, because actually we had a bed, it was available, we could work on that and then either move them to discharge to assess or actually move them out into their home, which is, you know, always the goal.
Simon, can you just tell us a little bit more as well about the discharge support workers, their roles and their grade, and how they interfaced with the discharged hub?
Yeah, so they were there was 8 to 10 of them initially, and they were all new into post. We had a previous iteration of our discharge support team where they worked very much face to face on the wards, gathering information, taking it away and passing it over. We wanted to kind of build on that when we rebuilt the service. During COVID, again, as I say, we pulled them all into our hub, which was located away from the wards, and we supported them with the skill mix above that of Band 5, Band 6 nurses and therapists, and some of our senior guys. We had good support from our quality team and our PMO office, and all of those people got involved, not just from a quality perspective or a PMO perspective, but everybody came with a bit of a background of knowing how this stuff works or had experience of how it had worked in previous parts of their life to enable us to get that information into everybody. And it really was a collaborative learning, I think, for everybody. And where we want to go with the discharge support team's role is to really get them as that key link between the wards, the family, the therapists, the doctors, and social care, to, you know, bring everything together to support that journey that the patient's on and help get them to where they need to be.
Thanks, Simon. And final question for you: are you planning on continuing the 7-day services, or do you think you will revert back to 5 days if that's what you were doing before?
Yeah, we're in a position where our ambition is to absolutely keep running 7 days a week, 8 till 8, but we've got staff constraints, unfortunately, and a lot of that's been down to people having to be redeployed back to their day job, or actually a lot of the people that were involved in this were people on maternity who were in that, you know, almost pre-shielding phase where they couldn't be clinical, but they could still come and work with us. So those guys have obviously gone off and had their babies, which is great. But that's reduced our stock of staff massively, and what we're looking to do is work out how we can build that back up. Our social service colleagues, they are doing an outstanding job. They are running 7 days a week. We're down to 1 call on Saturday and Sunday between acute and community and our social service colleagues. So that's one of our big challenges now that we're trying to overcome, but we'll definitely get there because it was so effective when we were doing it.
Thank you, Simon. That's great. If I can go over to Tracy now, please.
Hi.
Hello. Tracy, what's the procedure for discharging patients into domiciliary care, particularly around those patients who have been tested for COVID, either positive or negative?
So I suppose we've got a mixed picture across Warwickshire. We have got patients, so dom care providers who will accept positive, and then we have had some where there have been more challenging providers. What we did do, because I did speak about our blue beds, if it became that reablement or HomeFirst, etc., were unable to support that discharge home, then those patients were then considered to go into the blue pathways until we could free up or find an alternative provider across the system. So yes, so every patient would be discharged, would have had a swab prior to discharge, so we know what their COVID status is. And what we did was our single point of access, our integrated single point of access. Also, what happened was they received every single patient discharge and the status, and we set up a very quick system with our primary care colleagues and our domiciliary care providers and our local homes as well. So everybody was at very, very quickly aware of the status of the patient as well on discharge.
Were the blue beds, were they NHS beds or were they other
beds?
So they were joint commissioned. So we had a weekly joint commissioning board, and the funding streams were jointly commissioned. Health mobilised it because we recognised that some of these patients would need health requirements as well. And also it was because of the pathway 3 and our end of life, because simultaneously to this, one of our local hospices had to reduce their bed stock, and that meant that as a system the hospice beds were reduced as well. So included in those blue beds was the provision for pathway 3 and end of life as well.
Talking about pathways as well, what plans did you have in place for Pathway 0? Was there any safety netting? And that was from Sarah.
Yes, so there was Age UK provided the safety netting. So again, all discharges were then integrated single point of access was notified of all discharges, and Age UK then did a safety netting welfare check within 24 hours. Everybody had a named clinician, so if there was a problem, then that clinician was then contacted, and that may instigate a community response, consultant connect response from the community clinicians.
Were end-of-life patients included in your discharge to assess process, and were there any issues with that? And that was from Dee.
Yes, it was very much included as part of the pathway. As I say, one of our hospice providers wasn't able to sustain for I think it was about 15-16 beds that we lost out of that system. And but what they were able to do, and because we've got 4 hospice providers, and we work very, very well with them at all. And what we did, so at each place we had our silver calls, and our hospice providers became part of those silver calls as well. And so what happened was we started then working more collaboratively. We redesigned a whole pathway to care for patients at home. So we tried to offer more of a at-home end-of-life wraparound service between all the providers, and they held the ring on those referrals as well.
Did the role of the trusted assessor change at all during the COVID period?
It did. So the intention was, so we've got a very robust complex discharge team, and they are excellent, and they've always been responsible for our pathway 3 CHC. But obviously mindful of I suppose all the discharges, but how we work is simple and complicated discharges should be looked after by the wards, and the complex by the complex discharge team, because you know quite often they are extremely complex, some of those, so that's why there's a lot of energy going into that. Part of the change was that that pathway 3 complex discharges then became the responsibility of the CHC nurses. And so what the intention was then was that the complex discharge team were then going to take on the responsibility of all the care home discharges. And they did that, so it became a trusted assessment model with all of those care homes, because clearly nobody was going to come in and review, eyeball the patient. So that trusted assessment worked. It worked well with the complex discharge team taking on that role, but it probably wasn't as you know, the numbers, because of some of the other challenges with care homes accepting back their clients and any new clients, it became a little bit more problematic. But yes, where homes would accept, and some homes would accept, then the trusted assessment was in place.
And just while we're talking about roles and responsibilities, do you have a job description for the flow manager which you might be able to share? We've had some interest in people wanting to see what that looks like.
So we didn't really have a flow manager as such. So no, the answer is I can't share that because I haven't got one. But we each pathway, and we had a team coordinator. So whether it's just a title difference, we did have team coordinators who would be responsible to support that flow, but we didn't actually have a flow coordinator because the pathways are so distinct. It's, you know, it's quite clear on where each of those are going and which part of the service will be working on that.
Thank you. Does South Warwickshire have its own in-house reablement service, or are you reliant on private domiciliary care? And that's from Claire.
Okay, so reablement is part of our local authority, Warwickshire County Council, and they are employed and provided by Warwickshire County Council, and then they provide the reablement side of it, and then domiciliary care is separately commissioned by the local authority, Warwickshire County Council, as well. So it's two separate things.
How much has staffing been affected by the ability to be able to provide services?
So that's a really good question, because so we had to step down. So some of the guidance was about stepping down our priority 2 patients, and it was amazing. It was incredible how much capacity that created, and we did that by you know, working with other providers and carers, etc., to carry on. And it was the low level stuff, and it's that low level stuff that actually cripples the service. So that created a lot of space. But actually all our shielded staff, we actually managed to find some form of work for them. So whether that was that they did, and it was fantastic really, because actually our sickness improved, you know, because we were able to be more flexible. People were happy to work till, you know, on a call phone, answering our clinical triage questions. We'd rapidly trained them up. So every person, and I know this for a fact, every person within South Warwickshire Foundation Trust, I have to say at this point, not across the system, was given an alternative job if clearly they were well enough to take on that job, and so the capacity was created. The problem we have now is I suppose where we asked other members of the family or other providers to support, is that, you know, there is that carer fatigue that is hitting in now. So we are very much trying not to go back. We are monitoring our incidents and our datex to just check if there's been any adverse effect on any of these new ways of working, and so far it is looking very, very promising. But it's about how can we now make sure that we have we do shared care rather than all the responsibility being on one organisation. So how can we keep that safeguarding going? How can we assure the quality? And this is all part of our restoration and recovery plans. But we certainly know that there are opportunities there to support new ways of working, and obviously what we're working on now is what you know, our urgent plans and our well, we're calling it a 5-point plan, our winter readiness plan, because we expect that to be, you know, a very difficult one. And so that capacity has to be remained, but it's around, you know, how are we going to monitor these patients that may be low level. And so the beauty of our relationship with our system is that we're having these open discussions constantly. So can we see some different changes in roles? Can other providers take on some of this low level stuff with a very clear escalation up to health? And how can we build on what we've already had in place?
Thank you, Tracy. And just one more question. Just with reference to out-of-hours discharges and safety, in the community, with the community rapid response nurses being able to access CCOL beds during the night as a place of safety, has that been a consideration at all?
I don't know what CCOL beds is. Is that to somebody else, maybe? I don't know what a CCOL bed is. Should I know what a CCOL bed is? I don't know.
Do you want me to answer that?
That would be lovely, Liz. Thank you.
So there is only one hospital currently. Well, it's not a hospital. Some CCOL beds were developed at Headley Court, and which were developed as rehab beds, thinking we would need more for the post-COVID. There was a short period where it looked like they were going to fund those across the country, but actually they've decided they're not, because they're struggling to fill the beds at Headley Court because they've adopted the HomeFirst approach there. And interestingly, most COVID patients are younger and do not wish to go to another bed. They want to go home, which is exactly what older people want too. And we have paternalised them in a way that we haven't allowed that to happen. So CCOL beds, we're now talking about virtual CCOL beds, which will be in people's own homes. And Suzanne Rastrick is leading on how we develop those. So there'll be more information. They'll fit with discharge to assess. They'll be part of a HomeFirst approach. I hope that helps.
Thank you, Liz. I've got 3 questions now to ask all of the speakers, if that's okay. So, are there any? Have any of you experienced any difficulties with any homeless patients, and how have you overcome that?
Do you want me to answer that? It's Tracy.
Yes, please. Anybody?
Okay. Yeah. So it's Tracy. So yes, we did experience some discharge problems with homeless patients as well. But we do, and I think on one of my slides I talk about the housing team, and again, you know, as a system we were you know, really fortunate, because even pre-COVID we have housing liaison officers aligned into each place, and where possible our place-based teams, where we have our weekly MDTs, the housing officers, the local housing officers would form part of that meeting as well to advise. So again, there was already those connections with local people, and so very quickly, well, there was 2 cases that, if I'm really honest, were not very quick. And that really was more about the cases themselves. But we were able to sort of house these 2 cases. Well, there was more than 2, but we certainly were able to respond and house some of these homeless patients.
Thank you. Siobhan, just very quickly from a North Tees perspective, please could you share your single referral form? Would that be possible?
Yeah, definitely. I mean, we're adapting it as we go along, but absolutely we can send the draft that we've got at the moment. Just in response to the first question, from a North East perspective, we have, well, particularly in our area, homelessness isn't an area in Hartlepool pre-COVID. They had nobody homeless, so it's not so much of an issue within our area.
Thank you. And then finally, have any of you specifically commissioned any beds for dementia or delirium patients?
Our social service colleagues in Swindon Borough Council had delirium beds established prior to COVID, and actually due to some of the infection control risks, we stopped them. As a system, we took that decision, and now we're bringing those back online, because delirium, as we all know, it can be quite challenging when it comes to discharge, and especially rapid discharge. What we did in the interim was we looked after those people within our intermediate care beds, and enabled them to get as well as they could do before we passed them on to social service colleagues.
Thank you. Anything to say from Siobhan or Tracy on that?
No, I think we were very similar. We didn't have any specifically commissioned beds. We managed them within our intermediate care beds with our support with our mental health trusts as well.
Thank you. I think there are some other questions in the chat room, but we will go through those after this because of time constraints. And if there's any questions we can then answer afterwards, we will endeavour to do that. Thank you very much for letting me interrogate you for the last 45 minutes. So I'm going to hand back over to Callum now just to finish the session. Thank you.
Sorry, Angela, before you hand to Callum, there were a couple of questions about mental health beds. And just to clarify, this money, unfortunately or fortunately, was never intended to support acute mental health pathways from acute mental health beds. And the mental health teams are working on what it should look like for mental health, because probably their cohort of patients is slightly different than we're dealing with for this. So sorry, I just thought I'd answer that one.
Thank you.
Thank you very much, Angela, and thank you, Liz. And I'd really like to say a really big thank you to our three systems, to Siobhan and her colleagues, to Tracy Sheridan from South Warwickshire, and to Simon Lovett from Great Western Hospitals in Swindon. It really has been appreciated for you to take the time to deliver your presentations, give us an idea as to what you've faced over the last few months, which must have been a very difficult and tricky time. But I think it's really important to keep the home first message within the mindsets of all staff within the hospitals, because discharge isn't just about social care staff, therapy staff, it's about everyone in the hospital. On that note, myself, my ESIS colleagues have been writing a Home First practical guide, and we were hoping that would have been published along with Simon Stevens' phase 3 letter, so we're just waiting on it being published now. So it's just at the top of the shop at NHS England, NHS Improvement. Once that is available, you'll be able to get that on our Futures platform or on the Better Care Exchange. And just to reiterate, thank you to my Better Care Exchange, Better Care Fund team colleagues, for supporting us with this and in also developing the document, the Home First Practical Guide. We also had some input from the LGA and ADAS, so and lots of people to do with personalised care, homeless health, CHC. So there's some really great links in there and information for kind of anyone who wants to reinforce what they're doing with their discharge to assess. All of the slides will be sent to all the participants that are logged in and watching the webinar just now. As I said, if you haven't registered for the Better Care Exchange, the addresses you can see on your screen just now. The slides will be available, the recording will be available, and we will endeavour to get, we've got 74 published questions so far, and there's a couple of questions that weren't addressed, but we will try to do a frequently asked questions document. So just good luck with all the endeavours to support discharge to assess and your Home First models. Thank you for joining us, and we look forward to seeing you again soon. Thanks very much.